Okay, let's talk about this really cool case about post-abortion vaginal hemorrhage with DIC, or Disseminated Intravascular Coagulopathy. So this was a 23-year-old female. She's a G3P2, who presented to the ED with heavy vaginal bleeding right around the change of shift at 6:30 in the morning. She said she had an elective D&C the day prior for twin gestation at 13 weeks, and she says it went fine, no concerns. As she got home, she had light spotting, which became increasingly heavy, and by the time she got to the hospital, she was bleeding through at least a pad per hour. She was a healthy 23-year-old. She just had a history of iron deficiency anemia. On exam, she's tachycardic, she's hypotensive, she's diaphoretic and pale, she appears unwell, she's mentating well, she has mild suprapubic tenderness on abdominal exam, and when we went to do the pelvic exam, she passed out and there was bright red blood pooling in the vaginal vault. Initial labs show a hemoglobin of 7.3, platelet count 84,000, INR of 4, D-dimer greater than 20,000, and fibrinogen level that was less than 60. Initial treatment involved initiating massive transfusion with FFP, cryo, packed red blood cells, and platelets. She was intubated, she was Rh positive, so Rogaine was not administered, and OBGYN was consulted emergently. So this patient had DIC. So widespread hypercoagulable state, not restricted to the site of insult, in this case the uterus, but spread throughout the whole body. It is characterized by widespread activation of the coagulation cascade, leading to fibrin deposition in the vasculature. You can have organ dysfunction, consumption of clotting factors and platelets, life-threatening hemorrhage. And here's a good illustration of the pathogenesis of this, right? So first off, you have activation of the intravascular coagulation leading to platelet consumption, which is why those drop. Coagulation factor consumption, which is why those times go up. And then clot turnover or fibrinolysis, which is what the D-dimer increase reflects. And thus you have impaired coagulation and bleeding. And what this means is that there is endothelial damage, microvascular thrombosis, and then you can have multi-organ dysfunction, which is the kidneys, heart, and brain illustrated here, but any organ can be affected. So DIC is associated with high acuity clinical presentation secondary to severe or a life-threatening diagnosis. This can be infectious or non-infectious. Examples include malignancy, trauma, obstetric, vascular malformations, severe immunological reactions, and heat stroke. One Japanese study estimated DIC accompanied about 1% of hospital admissions. Another study looked at the incidence with patients with ALL, and before chemotherapy, it was about 12%, and after the vast majority of them developed DIC during remission induction. In patients with severe post-abortion bleeding, DIC should be considered. The incidence is estimated to be about 200 per 100,000 second trimester abortions. The clinical presentation varies quite widely. Patients can be asymptomatic or have overwhelming, life-threatening bleeding, as in the case of our patient. Typically, the etiology is known or quickly identified, such as infection, trauma, obstetric, etc. They will be bleeding from multiple unexpected sites, excluding the mouth, the areas of trauma or recent surgery, vagina, rectum, catheters, and the other devices. They may have hematuria, oliguria, or anuria if the kidneys are affected, and then they can have altered mental status or stroke-like symptoms if the brain is involved, chest pain if the heart is involved, and there's pulmonary symptoms. They can have hemorrhage, PE, etc. Skin will usually clue you in as you have microvascular thrombosis at the skin, which leads to petechia and purpura. Diagnosis is basically made based on the clinical presentation with abnormal laboratory findings, which includes increased PT and PTT, decreased fibrinogen as the body consumes clotting factors, D-dimer is elevated due to clot turnover, platelets and hemoglobin are low, and a peripheral smear of the blood will show schistocytes and fragmented erythrocytes. There is a diagnostic criteria which basically uses this description. Treatment is directed at the underlying condition. So for example, if the patient's in septic shock from infection, they need antibiotics. If they have placental abruption, they need emergent delivery, etc. You do need to reverse any clotting or bleeding dysfunction to try to stabilize them hemodynamically. That include packed red blood cells, platelets, FFP, and cryo. You may require heparin if they're not bleeding extensively. And here's an example of a massive transfusion protocol template, which is essentially the most senior person determines that this is life-threatening bleeding. You get all the baseline labs, then you activate the MTP protocol. In this case, in this protocol, it would be 4 units of RBCs, 2 units of FFP, and then you consider TXA, platelets, and cryo. And then you say, is the bleeding controlled? No, go back to that top. And if yes, stop MTP. And then on the right in the pink box, there's a lot of things you want to do to manage these patients as they're obviously critically ill. Just optimize their oxygenation and tissue perfusion. We're going to maintain normal thermia, right? And prevent acidosis, keep an eye on their calcium and all of the other labs. Okay, for case conclusion, the patient was resuscitated in the emergency department with MTP initiated. She went straight to the OR with OBGYN where she had a suction D&C. Interventional radiology performed a uterine artery embolization. They did a POCUS and did not find any free fluid in the abdomen, so they did not do an exploratory laparotomy. She was given misoprostol, oxytocin, and methergine perioperatively. She did very well postoperatively and was discharged on day 3. She never followed back up with our OB-GYN service and was subsequently lost to follow-up. So 3 key points about DIC is that it's characterized by widespread activation of the coagulation cascade, leading to fibrin deposition in the vasculature, organ dysfunction, and consumption of clotting factors and platelets with life-threatening hemorrhage. Diagnosis involves the clinical picture as well as laboratory abnormalities, low platelets, low hemoglobin, high PTNR, low fibrinogen, high D-dimer. And then treatment is directed at the underlying condition as well as supportive measures, typically involving blood products and clotting factors.